Hi guys, today we will discuss an important topic that comes in exam, Erb's palsy and Klumpke's palsy. Erb's palsy means upper part of brachial plexus is damaged because of undue traction or angulation between neck and shoulder that usually occur because of the birth injury. And then Klumpke palsy, it occurs because of excessive traction of upper limb, as you can see in the picture, and it is the lower brachial plexus damage. So what happens basically in Erb's palsy is that undue supination of the head from the shoulder, which can be in the birth injury or it can be below shoulder injury, and many nerves they are involved. And usually the position of the child or the patient is that is adduction and medial rotation at shoulder joint, extension at elbow joint, and pronation at radioulnar joint as this man is receiving tip from someone. So this is the position in the Erb's palsy, while in Klumpke palsy there is wasting of the small muscles of hand and clawing of hand. Here you can see in the picture L1 and L2 area in inguinal ligament, then after that L2, L3 front of thigh, then L3 and L4 knee and medial aspect of leg above medial malleolus, and the area just above the medial malleolus is L5. L4 it also covers the dorsum of the foot except little toe and lateral border of the foot and lateral part of lower leg, which is covered by S1 and L5. Then after that comes the dermatomes of the upper limb. You can see that in the infraclavicular area there are dermatomes C3 and C4. Then after that upper part of the biceps is actually innervated by C5, C6. Inner part of the arm is supplied by T1. This C5 and C6 they innervates the lower arm as well as the thumb and the index finger, while the middle finger is innervated by C7, and the little finger and the hypothenar eminence and the lower medial arm is supplied by C8 and T1. Then individual nerve palsies, they are also very important. Musculocutaneous nerve damage, it leads to weakness in flexion of the elbow and supination. Isolated injury is very rare. Then after that comes axillary nerve damage, which leads to weakness of shoulder abduction, and sensory loss is in the lower area of deltoid muscle. Then radial nerve damage, it leads to wrist and the sensory loss is in the small area between first and second metacarpal bone. Median nerve damage, it leads to the weakness of the loaf muscles, that is lumbricals. Then after that opponent's pollicis, abductor pollicis brevis, and flexor pollicis brevis. So it leads to loss of pronation of forearm, and then wrist flexors. They get weak. Then after that ulnar nerve, that leads to the sensory loss in medial 1.5 fingers, and it also leads to weakness of all intrinsic muscles of hand except loaf muscle, which are supplied by median nerve. And damage of ulnar nerve, it leads to claw hand, that is hyperextension at metacarpophalangeal joint and flexion at interphalangeal joint. Then long thoracic nerve, it leads to winged scapula, that is the medial border of scapula, it gets prominent.